Hello and welcome to HFTV. I am Dr. Darshan Jhala and I am here to discuss a very important, relevant clinical problem which we see in our day-to-day practice. As cardiologists, we see many patients with reduced ejection fraction. Now this disease has been renamed as HFREF. This is a relatively progressive disease with 50% mortality in the 5 years. These patients either have progressive deterioration in their LV function or they have sudden cardiac deaths. And though some of the new drugs like the ARNIs have shown some benefit in these areas, cardiac implantable electronic devices, also known as CIEDs, are the mainstay in management of these patients and they have been proven superior to drugs. However, these devices require proper patient selection to optimize patient benefits. So the question every cardiologist has in his mind is, does every single patient of HFREF require a CIED? To help solve these queries, we have three eminent electrophysiologists, Dr. Jagmeet Singh, Dr. Rajnish and Dr. Ajit with us, who are going to take us through proper device selection. The trials which drastically changed our outlook towards these devices were the MEDIT trials, which suggested that all patients with an ejection fraction of less than or equal to 30 require an ICD without any further testing. So Dr. Jagmeet, maybe you are a part of MEDIT-2 trial. Could you tell us how this figure of 30% was arrived at?
Sure. No, that's a great question. So we were a part of the MEDIT-2 trial. I think much of the design of that study was based off the results of MEDIT-1, as well as the MUST study. As you know, those two studies actually transpired much earlier compared to the MEDIT-2 trial. And what they found in those two studies is that electrophysiological testing in patients who had an EF less than 30% really did not have the same positive predictive value or the sensitivity or specificity, whatever you want to call it, in that subset of patients. They found that if you did an EP study in patients less than 30% and you induced VT, they actually landed up having ventricular tachycardia, but if you didn't induce anything, they landed up having VF. So they found that the additional use of electrophysiological testing or risk stratification didn't really contribute too much. And then they chose an EF of 30% because they really wanted to enrich the population to find a subset that was really at high risk in a post-MI group. And so that was the thought process behind really sticking to an EF of less than 30% in the post-MI group without EP studies.
So now we have almost 20 years of MEDIT experience, our own experience. So, and we have enough data of our own. So Dr. Rajnish, how has this trial impacted in your practice? Have you changed your practice since MEDIT-2?
Actually, if you say it was a landmark trial, and as mentioned by Dr. Jagmeet, I think MEDIT-1 followed by MUST and MEDIT-2, all three changed the practice scenario worldwide, and it had to have an impact on our practice and in India. Still, there are a lot of people who do not believe in primary prevention in as per MEDIT-2. The reason being that developing economies still can't afford. It's a very large population of patients who would be ejection fraction less than 30% post-MI, which would mean a huge economy drain on the society. But as a private practitioner or as a guideline advocated, we definitely offer it to patients, and I push it forward towards patients who are younger, who are stable post-MI, who are people who can afford, who have a good longevity, rather than pushing it into people who are elderly post-MI ejection fraction below 30%. But yes, I do mention and offer and make a fair assessment on the economic status. So if the socio-economically I feel they can afford, I do apprise them about the recommendations that they should get an ICD since their ejection fraction is below 30% and they have good prognosis with that, and the only thing which impacts them is that they can die suddenly. So in these class of patients, I do make them aware of it, prime them, let them come back to me again, and over the time we discuss, and once they're also read about it, I do offer it and do try to practice MEDIT-2 guidelines as well as possible.
I think it's more of convincing ourselves that we need to convince the patients rather than considering economics. You see, it's not very expensive. It can be done.
Right.
In private practice, I don't think it is very difficult. So
Right,
These
but-
trials convinced us that we need to convince somebody.
But ICD is still a big event for a patient. If you see from there, psychologically, sometimes they take a hit. It's not only by economy, the requirement of recurrent replacements, which could be, initially it used to be every 4-5 years. Now they last you good 9-10 years as well. The shock itself can be very disabling. So they have to be primed about all this, that we are going to go for a change in their lifestyle. It is not that something you've put it and you've forgotten about it. So it has an impact, and we definitely take a mutual decision, apprising them of all the probably pros and cons.
Dr. Ajit, a certain subset of high-risk individuals were identified in these many trials who could actually benefit. Paradoxically, these were the same patients who had poorer outcomes.
That's right.
So how do you tackle this paradox?
See, it is quite interesting as to why different geographies have different ICD implant rates. If you look at the Indian rate is around 5 per million. The standard would be about 50 per million in the UK, and in the US about 200 to 500 per million. So why this difference? Because most of the Indian electrophysiologists do not necessarily accept this primary indications. So is it true that every patient with ejection fraction of less than 35% warrants an ICD? And why do we not do it? Are we not convinced of the data? So when you look at in the first 2 years of a patient who has a classic MADIT criteria, they don't really benefit. They benefit after the 2 years. So then we need to find out other indicators which have a high risk component where we can straight away give an indication. So there are some risk factors have been identified. One is patients who have elevated serum creatinine, ejection fraction less than 25%, who have atrial fibrillation, and I would in addition add patients who had NSVT. And if none of these criteria do satisfy, what we do as a criterion is patients with high risk, we then put them for an EP testing, which people do not necessarily accept. But if they have reduced ejection fraction, a high VPC load, if you put in for an EP testing, and if you have a VT, then we would take them up for an ICD implant. But as such, these high risk criteria would qualify for a rather better benefit in terms of an ICD implantation.
So if I can just add to that, I think both the comments are really important. Is that shared decision making is important. So making the patient a part of the whole discussion is essential, and really kind of making sure that it's not being enforced upon them is an important part. But at the same time, I get what you're saying is that sometimes we have hesitancy within ourselves whether it's the right therapy, and I think that's a really important question to raise, because we do need to implant at least 18 to 17 ICDs
Yes,
to
the number
reduce
needed to
death
treat.
in one person. So the number needed to treat is actually is not exactly the right, and I think is not convincing enough. And I think that is largely because our risk stratification strategies are not good enough. And I think that's going to change. I think over time, as the data sets get better, population-specific data sets get better, as we get more artificial intelligence strategies to really kind of develop population-based risk stratification strategies, I think we'll be able to better pinpoint which patients get and need these devices. Obviously, we're not there as yet, and I think while we're not there, trying to enforce the guidelines makes sense as much as we can, and obviously being fiscally responsible at the same time.
There was a study which looked at as to why, whether physicians do believe in these criteria across, I think, in the US and other countries. What they found that not all of the physicians do really believe in the guidelines. Only about 30% believe. So there is a big stumbling block that the physicians, whether the intake of the guidelines is necessarily actually an intake.
So can I expand on that? I think there are two kinds of physicians, the electrophysiologist and the non-electrophysiologist. The electrophysiologist feels that we're not actually implanting enough, there's not adequate market penetration, whereas a non-electrophysiologist feels that we're probably implanting too much because we've implanted the ICD in their patients and they never really got a shock for the last 10 years. That's one. And second is their patient actually died suddenly from other reasons, and they feel that maybe the ICD would not have helped in those particular patients anyway. So there's a little bit of discordance when you do this survey between a cardiologist who's an electrophysiologist and a primary care physician also.
But personally, you do advise every single patient with a low HF to counsel them.
Totally. I think anybody who meets the guidelines, anybody who has an ejection fraction less than 35%, off the cuff, I will talk to them of the risk of sudden cardiac death, and I will educate them about the different studies that exist. I will tell them that it's an imperfect science, and there's a good chance that you may never need this device, but it's going to serve like a little angel that will look after you in case you ever had an arrhythmia. It will shock you. So I think a part of the issue is also how we actually convey that message across to the patient to help them understand it. And I think the technology has gotten better. Our implant strategies are better. Complications are markedly less now. So I think it's a safe way of ensuring that the younger population, as you alluded to, stay safe.
Yeah, basically I think for every patient who gets a shock, there's a large number of patients who do not get a shock, which is creating a doubt amongst the physicians. Amongst 10 patients, only one benefited. So if they feel 9 were an overkill kind of a thing.
Totally.
Okay, so let's shift to CRTD. Dr. Rajnish, how do you select your patients for CRTD?
That's a wonderful question. I think the guidelines are very straightforward. For me, any patient who's got a LVEF of less than 35%, the first thing I look at is the ECG. So a classical patient would be a normal sinus rhythm, left bundle branch block, QRS more than 150 millisecond preferably, but at least 120 millisecond and over. NYHA class 2, 3 or 4. So they should be at least mildly symptomatic, and their life expectancy should be more than 1 year. They should not have had a recent revascularization, and they should be chronic heart failure for 3 months at least. So that will be a classical case which is likely to benefit. Patients also who have not a classical left bundle branch block, but they have QRSs which are wider than 150 for sure, preferably, and NYHA class 3 or 4, which would mean they are symptomatic and less than normal activity, I would still offer them a CRTD.
Dr. Rajnish didn't mention anything about echo. So I don't think he considers echo as an event. What is your take on that?
Yeah, I think echo, basically CRT is electromechanical resynchronization, but it is more of an electrical resynchronization. So the data from the echo trials which have not really shown much of benefit if you're using echocardiographic criteria. So I think the best way to go around is basically QRS duration and left bundle branch block. And specifically, typical left bundle branch block, which makes a responder, and atypical left bundle may not necessarily make a good responder. So I think the reason why echo is not shown, and I really think we should be dealing with electrical resynchronization rather than mechanical. No way it effectively comes out in the end.
Totally. No, I completely agree. I think our echocardiographic measures of mechanical dysynchrony have had a problem. They're not always reproducible. There's a lot of inter and intra-observer variability. And then we did this really nice study, I think, which you alluded to, is the echo CRT study, where we looked at narrow QRS, so QRS about 130 milliseconds and lower, but with evidence of mechanical dysynchrony. And we found that it actually did not help in selecting patients and identifying who would actually do better. And I think a part of that, as you alluded to, is that it's more of an electrical problem rather than a mechanical problem that we're dealing with out here.
I guess the only way echo helps is to rule out significant valvular disease, which will contribute to heart failure. So if you have severe mitral regurgitation, that patient is unlikely to respond very well to CRT. So I think these are some of the...
So I have some thoughts on that, if I may say. So sometimes you have mitral regurgitation because of mechanical dysynchrony. Your papillary muscles don't come in time, as a result of which you have dysynchrony associated mitral regurgitation. So if there's a way of actually assessing that, and there are some echocardiographic strategies actually saying that the coaptation or the tenting of the valves is kind of desynchronous out here, CRT actually helps mitral regurgitation in that particular setting. I think where echo really helps is helping categorize, is there RV dysfunction? Is there pulmonary hypertension? Is the LV really significantly dilated and thinned out and scarred? Then maybe the response is not going to be that great. So it helps us risk stratify patients, but I totally agree it also helps us understand the severity of the valvular heart disease, because if somebody has aortic stenosis, whatever you do, you're not going to change their lifestyle or impact their quality of life.
I've been specifically trying to look at what really makes difference of this response and these left bundle branch block related CRT resynchronization. I think it is those ones which have transapical activation. not a transseptal activation. Only these are the ones which really help, and specifically shown by those non-invasive cardiac mapping or electrical LV actual mapping and seen that patients or people with a left bundle branch block, typical U-shaped activation, right, typically helps.
Yeah, and that's a really good point, because when you substratify a left bundle branch block, you can have a left bundle branch block with a normal axis, a left axis, and a right axis. And it's the left bundle branch blocks with a normal axis which have your typical activation sequence actually do much better than a left bundle branch with a left axis or a right axis, because there the activation sequence is a little different, and then positioning the lead along the lateral wall doesn't necessarily translate into a better outcome. So there is something to be said about what you just stated.
And the echo can't pick up this.
And the echo can't pick up that. Exactly. So there's still a lot in the EKG signal that we can decide how patients are going to respond or not going to respond.
We still use echo a little bit for sometime for post-implant optimization as well.
Yeah.
Exactly.
Not as a part of the criteria, but it does helpful. It's
Totally.
Dr. Jagmeet, HFREF is actually defined as EF less than 40%. We have been talking about patients with 30% EFs. So what about that gray zone of between 30 and 40? What do we recommend to them?
Absolutely. So I think I would, so it depends on which guidelines you look at. Usually they use 35% and lower as the HFREF. It's the 35 to 40% that become the gray zone. I think it's a gray zone in the post-MI patient population. The patients who had an MI and have an EF between 35 and 40%, the only study we have that can help guide us is the MUST study.
Yes.
So we're compelled to do an electrophysiological study to see if we can induce an arrhythmia, and if we can, then we go down the path of putting an ICD in. So that patient population needs some risk stratification. However, if it is a non-ischemic cardiomyopathy between 35 and 40%, I would probably just, I would say give them better medical therapy and wait and watch and see how they evolve.
So that was my next question to you.
Oh, really? Okay.
What is the take after the Danish trial?
So the Danish trial is actually an interesting trial, and I think it really needs to be put into perspective, right? So the Danish study, I think if I remember correctly, it randomized about 550 patients into control arm and an ICD arm. The interesting thing of that study was that half the patients in the control arm and half the patients in the in the ICD arm actually got CRT therapy for wide QRS. Okay. So because of that, when you looked at the overall outcome in terms of mortality, there was really no difference in those two patient populations because they kind of overlapped. And then people said, you know what? ICD don't work in non-ischemic cardiomyopathy. But I think the underlying thesis out here is a little different because those patients with a wide QRS got a CRT device. When you look at the substratification of this Danish study into CRTD versus CRTP, they found that the CRTD actually reduced arrhythmic death more than the CRTP. So there's still some value for CRTD. Now, the SfHFTCON study, which is the only study which actually gave us the indication that CRTD, that ICDs are required in non-ischemic cardiomyopathy, actually was a very different study. They included wide QRS patients who did not get CRT. It was because the study was done much earlier before CRT became a common therapy, right? They also included patients that did not get maximal medical therapy like the Danish study got. And the Danish study also had NT-proBNP levels that they use as inclusion criteria. So we're trying to compare apples and oranges. So to answer your question more succinctly, I still follow the conventional guidelines. And if a patient has non-ischemic cardiomyopathy, I will offer them an ICD because until we don't have another clinical trial that shifts the balance out here, I would probably give them a defibrillator. However, if there's a patient who has a classic left bundle branch block and it's a young woman and we have a discussion and they'd rather not go down the defibrillator route, I would feel quite comfortable also just giving them a CRTP and then waiting and seeing how they do. It's a long-winded answer for a simple question.
The event rates were very low in Danish actually, so there were hardly any endpoints there. And that was one of the reasons I think it was underpowered to basically.
Right.
Dr. Ajit, do you really rely on cardiac MR to decide about ICD in a DCM? I mean, that's the way everybody seems to be looking at more the fibrosis, more the indication to put in. I mean, do you follow this in clinical practice?
Yeah, we had a MRI, interested group of people who are looking at specifically at the MRI and the need for or arrhythmia evaluation in a patient who has a DCM. I think MRI does help. And if you are looking at the, but what we saw was that only 50% of them have any significant delayed enhancement, which is seen in these non-ischemic cardiomyopathy patients. But if they do have, and if the percentage of involvement of this fibrosis or this delayed enhancement is more than 15%, so we call this rule of 15%. If it is more than 15%, then they are a chance of having arrhythmia which is more, in which case there may be an indication to put an CRT-D rather than a CRT-P. So those of us who believe that you need more specific arrhythmia indicators for a CRT-D, then MRI certainly is a component. You could also look at other criteria for heterogeneity of the scar in these MRI-based ones, and typically that helps more in patients with ischemic cardiomyopathies. But I think MRI does help. Sure.
Dr. Rajnish, we are now coming to an end. So could you just give the audience the take-home messages?
The take-home message would be, I think there's no controversy as far as the secondary prevention is concerned. Ejection fraction less than 35%, if they've had an event, documented VT, resuscitated sudden cardiac death, or a syncope, which is thought to be due to a malignant ventricular arrhythmia, ICD is definitely indicated. They may in addition be basically candidates for a CRT alongside. Number 2 would be all patients of LVEF less than 35%, LBB, QRS more than 150 or QRS more than 120 should be candidates for CRT-D. In case they do not want to take a CRT-D, at least for CRT-P, and they should be told about the indication for in a non-ischemic. In ischemic, there is no controversy. They should all get a CRT-D. Non-ischemic, there is a controversy whether the ICD in addition to CRT will help or not. And number 3, patients with ejection fraction less than 35% narrow QRS would be candidates for ICD. That would be 3 takeaway for me.
Thank you.